This poster will present two rare cases of endocrinopathies in patients with metastatic cancer treated with checkpoint inhibitor immunotherapy. The emergence of cancer immunotherapy has instigated a new era in oncology. In 2011, immune checkpoint inhibitors were approved by the FDA for treatment of solid and hematological malignancies and have had remarkable results. Unfortunately, since their release, new cases of endocrinopathies have been reported, and patients are now developing new diagnoses lifelong after battling cancer. And missing these rare endocrinopathies could be fatal. The first case is a 47-year-old male with metastatic melanoma who's coming in for 5 days of polyuria, polydipsia, nausea, and vomiting. He has no prior history of diabetes. He has melanoma of his lower back several years ago with inguinal lymph node metastases, and he underwent a wide margin excision at that time. Unfortunately, 3 years later, he developed hematuria, and CT chest of his abdomen and pelvis, along with a PET scan, confirmed metastatic disease to his lungs, bladder, as well as his back and gallbladder. He was put on nivolumab and ipilimumab by his oncologist. When he presented, he was afebrile, but he had a pulse of 114, normal blood pressure, and tachypneic to 22, but sitting well on room air. He was generally pleasant and cooperative. He did appear tachypneic and fatigued, and his abdomen was soft and non-tender. His lab results on presentation showed a leukocytosis of 19 with neutrophilia. He had a low sodium of 129, elevated potassium of 6.2, a low bicarb, and an elevated creatinine of 2.4, up from his baseline of 1. His glucose was very elevated to above 600. He had a positive anion gap of 26 and positive ketones. He was diagnosed with DKA and appropriately treated with IV fluids and insulin drip. His A1C came back the next day at 7.1%. His pseudohyponatremia was in the setting of elevated glucose levels, and his potassium was elevated in the setting of AKI from dehydration from DKA. All of these abnormalities resolved with treatment of his DKA and fluid hydration. He was tested for adrenal insufficiency, and his cortisol in the morning was normal, and his thyroid labs were also unremarkable. He was not given stress dose steroids. Because of his undetected C-peptide level, he was diagnosed with type 1 diabetes mellitus or autoimmune diabetes mellitus and was put on an insulin regimen and followed up outpatient. He was not resumed on his prior immunotherapy. Second case is an 81-year-old female with metastatic bladder cancer who presented with 2 weeks of fatigue, dyspnea, and positional dizziness. She did come in recently with hyperkalemia to the emergency department and was treated with IV fluids, which resolved her elevated potassium levels. She denies any fever, chills, dysuria, or abdominal pain. Her bladder cancer was diagnosed several years ago, and she underwent transurethral bladder resection 3 times. Unfortunately, 4 years later, she developed mediastinal metastases and was put on cisplatin and gemcitabine. Despite these agents, her cancer progressed, and her oncologist switched her to Keytruda or pembrolizumab, which was a new agent. On presentation to the hospital, she was afebrile, but she was hypotensive with a blood pressure of 81/59. Normal respiratory rate, and sitting well on room air. She was pleasant and cooperative, but she was dyspneic in the room, and she had dry mucous membranes and a low JVP. She did not have any skin hyperpigmentation. Her lab work was not significant for any elevated white count. Her electrolytes were also unremarkable. She did have an elevated D-dimer of 1.99, which prompted the ED physician to get a CTA of her chest, which did not show any PE or pneumonia, but did show lymphadenopathy. She had a CT abdomen pelvis, which was unremarkable. She had an elevated troponin, but she didn't have any chest pain, and this plateaued. Her lactic acid and procal were unremarkable. Because of her positive UA, which showed mild 2+ leukocyte esterase, some white blood cells, and bacteria, she was admitted with septic shock from urosepsis and was put on empiric antibiotics. Despite this treatment, the patient remained hypotensive throughout her stay, and further workup was indicated. An AM cortisol level was undetected, and a concentropin stim test was positive with cortisol levels that did not elevate to ACTH. And her ACTH level came back at 458, indicating a primary adrenal insufficiency in the setting of immune checkpoint inhibitor use. Her CT abdomen did not show any adrenal nodules or masses, and 21 hydroxylase enzymes were not checked. She was put on hydrocortisone and followed up outpatient with endocrinology. Because she was hypotensive and dizzy, still on hydrocortisone, Florinef was added, and patient felt better. 6 immune checkpoint inhibitors have been approved by the FDA, and these include CTLA4, PD-1, or PDL1 agents. These agents are T-cell surface receptors, and they will cause inhibition when they bind to their ligands, and they will they serve to limit the immune response. This is a way for our body to prevent T cells from attacking normal, healthy tissue. Tumors actually manipulate these inhibitory pathways to evade rejection. Inhibitors of these checkpoint receptors, such as the ones that mentioned in the PowerPoint, will no longer halt the immune response, allowing the T cells to attack cancer and result in effective cancer treatment. However, such a robust immune response by the T cells can also go on to attack healthy tissue, and actually attacking endocrine tissue such as pituitary, pancreas, or adrenals is extremely common, resulting in hypothyroidism, hyperthyroidism, hypophysitis, primary adrenal insufficiency, or insulin-deficient diabetes. It is, of course, higher with combination therapy, such as nivolumab and ipilimumab, like in our case number 1. Thyroid dysfunction remains the most common abnormality, and it can be life-threatening, a thyroid storm. Anti-PD-1 agents are the most common to cause this. Thyroiditis is common because the thyroid gland actually produces PD-L1 and PD-L2 molecules. Hypophysitis is the most common with ipilimumab, which is a CTLA4 protein expressed in the pituitary gland. Primary adrenal insufficiency is very rare, 0.7%, and insulin-dependent diabetes is common with anti-PD-1 therapy and ipilimumab. Current guidelines recognize that these effects are extremely dangerous if not recognized, and patients are undergo screening when they're put on these immune checkpoint inhibitors with baseline TFTs, cortisol, and ACTH, and then screening regularly thereafter. The diagram here shows that without immunotherapy, the tumor cell can easily inactivate the T cell and evade rejection by the immune system. With immunotherapy, by blocking these receptors such as PD-1 or PD-L1, the T cells are activated and they go on to effectively treat or kill the cancer. However, they can also go on to attack healthy tissue, resulting in endocrinopathies. It is very important for physicians to recognize that these endocrinopathies can be fatal and to always keep in mind and screen patients appropriately. Thank you.